Okay, so let's get started. It's my pleasure, absolute delight to introduce our kickoff speaker for our GW seminar, examining dementia across the public health spectrum. And our first speaker is Dr. Elizabeth Rose Mayeda. She's an assistant professor of epidemiology at the UCLA Fielding School of Public Health. And for most of her career, which hasn't been that long, but long enough right now, she is focused on really identifying modifiable determinants of cognitive decline. And her research especially addresses the issue of health equity. So with that, I'll introduce the topic toward health equity in brain aging, non-traditional data sources and innovative tools. Take it away.
Hi, thank you, Loretta. I'm so excited to be here today. Can everyone see my screen? It looks like a title. Okay, great. Okay. So today I'm going to talk about my research on health equity and brain aging, particularly cognitive decline and dementia. And I see health in old age as really representing the accumulation of exposures throughout the life course. So I take a life course perspective in my work. And with the goal of achieving health equity in mind, I think we really need to carefully characterize the extent to which disparities currently exist, which includes careful descriptive work and consideration of who is represented in our studies. And additionally, we need to conduct research that will eventually inform development of effective population level interventions, which means that I'm interested in estimating causal effects. So applying methods to improve causal inference is also, I think, really central to the goal of achieving health equity. So two of the areas where I see the field really making progress in that I'm interested in are really addressing some of the limitations of past research, which includes one, that a lot of the past research on dementia has been conducted largely in non-Latino white, often highly educated cohorts. And also I think traditionally dementia research has struggled with methods, in particular struggling to think causally. And I think this is changing, and I'm very excited also about this progress as well. And I think that doing research in populations with more diverse life experiences and applying robust methods will really contribute to identifying modifiable determinants of dementia and also promoting health equity in brain aging. So a couple of methodological challenges in dementia research I just want to highlight to start off, because I think it frames some of the important challenges with thinking about how to promote health equity in brain aging. And one is obviously the diversity of the study sample. So obviously you can't document and understand racial and ethnic inequalities in dementia if you only study non-Latino whites. And I think we're not only interested in having studies that represent racial and ethnic diversity within one sample, but then also we're really interested in within any one racial ethnic group also having diversity in life experiences within racial ethnic groups. Measurement is another key issue, especially in educationally, ethnically, and linguistically diverse populations. And because we can think about if we're trying to understand racial and ethnic inequalities in dementia, differences in measurement across racial ethnic subgroups could, for example, lead to delays in diagnosis in some groups relative to others, which could lead to spurious differences in incidence rates. So when we're thinking about documenting and understanding racial and ethnic inequalities in dementia, measurement of cognitive function and diagnosis of dementia is really key. And then a methodological issue that's really near and dear to my heart is sample selection. So thinking about selection into our samples, as well as selective attrition from the study samples. And I'll talk a little bit more in detail about that. There are many other methodological challenges, but these are some of the key issues that my work today that I'm presenting will touch on. So in terms of some of the motivation for my work on racial and ethnic disparities in dementia, Reducing racial and ethnic disparities in dementia was identified as a national priority by the National Alzheimer's Plan that was signed into law by President Obama in 2011 to outline national priorities for Alzheimer's disease research. But really in 2011, when the NAPA was signed into law, there really wasn't very much evidence about the extent to which there were racial and ethnic disparities in dementia. And it's really difficult to identify and implement effective strategies to reduce health disparities when we're not even sure to what extent they exist, which means that for dementia research, over the past 10 years, there's really been a need for even this first generation health disparities research, which is to really document the extent to which there are racial and ethnic inequalities in dementia. So prior to some of the research that I'm going to present today, there were no published studies of dementia incidence samples representing the diversity of the United States. Most studies on racial and ethnic inequalities in dementia have only included 1 to 2 racial and ethnic groups, for example, Black and white Americans, but the picture was really incomplete because we didn't really understand to what extent we didn't really understand dementia rates in other racial and ethnic groups. The studies documenting Black-white inequalities of dementia incidence documented significant disparities in dementia incidence rates for Black versus white Americans. But really trying to piece together evidence for other racial ethnic groups, we were really left to trying to look at dementia incidence rates across different studies. This is really challenging because dementia rates can be really sensitive to diagnostic criteria. That doesn't mean that one study has good diagnostic criteria, another has bad diagnostic criteria, but slight differences in diagnostic criteria, even if both studies have valid protocols, could contribute to differences in estimates of dementia incidence rates between studies, which can make it really difficult to try to compare dementia incidence rates, for example, between different studies. And then another challenge with trying to compare rates across different studies is that geographic patterns can also contribute to differences between studies. So for example, for a long time, the only studies looking at dementia incidence rates in Latinos in the United States were the SALSA study, the Sacramento Area Latino Study on Aging, based in the Sacramento area of California, and the YCAP study, the Washington Heights Inward Columbia Aging Project, which includes non-Latino white participants, Caribbean Latino or Hispanic participants, and non-Latino Black participants. And so for a long time, these were the only 2 studies that we had to document dementia incidence in Latinos in the United States. But you can imagine that not only could we be concerned about possible differences in diagnosis between these 2 studies, but also really differences in experiences of Latinos in the Sacramento area, which are predominantly Mexican Americans and Central Americans, and predominantly Caribbean Latinos living in New York City. So to summarize, reducing disparities in dementia, I think, is a really major priority for dementia researchers. It's really, I think, become more recognized by the field as an important goal over the past decade or so. But there is still this need for first generation health disparities research, which is clearly documenting disparities. So today I'll talk a little bit about some of my work on racial ethnic inequalities in dementia using data from the Kaiser Permanente, Northern California. So Kaiser Permanente Northern California is an integrated healthcare delivery system with over 4 million members. The members are fairly representative of the overall population of the geographic region, with the exception that it tends to underrepresent people at both extreme tails of the income distribution. There are a couple of things that make Kaiser Permanente Northern California really rich resource for research. So in addition to the membership being fairly representative of the region, also there are people who are really long-term members. People often stay with Kaiser for a really long time. And another really cool thing is Kaiser started electronic medical records really early. They were really on the forefront of transitioning to electronic medical records, and they had electronic medical records system-wide starting in 1996 in Northern California. So for the research that I'll be presenting today, we looked in the EHR, we identified all health plan members who were ages 60 years or older at the dawn of the electronic medical record system in 1996. Because we really wanted to make sure we were getting incident dementia cases, we then implemented a 4-year washout period. And then we looked at, as of January 1st, 2000, who was still a health plan member with no prior diagnosis of dementia in that 4-year period. And then we followed people for 14 years for incident dementia based on diagnosis in the medical record. Here's a brief summary of the characteristics of the sample. And there are just 2 main things I'd like to summarize. First is the diversity of the sample. A huge appeal of Kaiser is that it's very large and has fairly large ends for even racial ethnic groups that make up a smaller relative proportion of the sample. And to include 6 of the major racial ethnic groups in the United States. And second, it's really key that this research is really based on dementia diagnosis in the medical record, which means that people need to be in contact with the healthcare system in order to get a diagnosis that shows up in our study. And so here I want to just highlight that healthcare utilization in this population is high. Here I have, I'm showing the percentage of each racial ethnic group that had at least 1 healthcare visit per year for each of the 4 years in the washout period. So you see that it varies some across racial ethnic groups, but on average, we see about 80% or more of people with at least 1 healthcare visit per year for 4 years in a row. So here are age-adjusted dementia incidence rates by race ethnicity. We see that dementia incidence rates are highest in African Americans, consistent with prior research, followed by American Indians and Alaska Natives. And to my knowledge, this is the first study to look at dementia incidence rates among American Indians and Alaska Natives. Rates were intermediate for Latinos, Pacific Islanders, and non-Latino whites. And this is actually consistent with findings from the SELSA study that I mentioned earlier of Latinos in the Sacramento area of California. Our estimates of dementia incidence rates in Pacific Islanders, as you'll see, are not very precise because this is the smallest racial ethnic group included in the study. But because there were no other documented evidence on dementia incidence rates in this population, we thought it was important to include this information. And interestingly, dementia incidence rates were lowest in Asian Americans, which is fairly consistent with some of the only prior evidence on dementia incidence in Asian Americans, and these studies of Japanese Americans suggested similar or possibly lower dementia incidence rates in Japanese Americans in Hawaii and in King County, Washington, compared to non-Latino white cohorts. And I want to just highlight that, of course, each of these broad racial ethnic categories includes really diverse individuals. And based on the demographics of the Bay Area, diversity of the Asian American sample was a major concern in particular. And so in a follow-up paper, I examined dementia incidence rates among Asian American subgroups. And here we see that although we observed some differences, some heterogeneity and dementia incidence rates across Asian American subgroups, we see that dementia incidence rates are lower in every Asian American subgroup that we examined, including Chinese Americans, Japanese Americans, Filipino Americans, and South Asians compared to non-Latino whites. And we currently have an ongoing project where we have a sub-sample of a few thousand Kaiser members who took a survey where we have a little bit more information about them and their sociodemographic characteristics besides just the electronic medical record to try to understand heterogeneity in dementia incidence rates among Asian Americans better. So this work that I presented is the first work to directly compare dementia incidence in a sample representing the racial and ethnic diversity of the United States. and really the findings substantiate and extend the findings from previous studies. So it was, I think, somewhat reassuring. You know, we're working with EHR data, and it was somewhat reassuring that for some of the racial ethnic groups, we had some information from other data sources that our findings seemed consistent. So it seems like nice triangulation of evidence from studies with different strengths and weaknesses. And I think in terms of thinking about possible a possible positive outlook on these results, or that when we see heterogeneity in dementia incidence rates across racial ethnic groups, it also suggests that I think we can think that if social factors are the primary pathways, which I believe is probably the case, that the findings really suggest that it means that substantial reductions in dementia incidence are really possible. But one important caveat is that the outcomes in these studies were dementia diagnosis in a medical record. And as I mentioned to you before, delays in one population compared to another could really lead to spurious differences in estimates of dementia incidence. So this is part of the motivation for the next project, which is also of great importance for persons living with dementia and their family, which is to examine how long do people live after a diagnosis of dementia. So I was motivated to do this work because I really tried to think about, you know, I had all of this EHR data. What could we really do with the EHR data to try to test to evaluate in the available data that we had the extent to which differences in timing of diagnosis could really contribute to differences in dementia incidence that we saw in the work that I just presented. And this conceptual diagram demonstrates how differences in timing of dementia diagnosis could contribute to estimated differences in dementia incidence. And the motivating assumption of this is that dementia influences mortality similarly across racial and ethnic groups because there are currently no disease-modifying treatments for dementia. So as a result, delayed diagnosis would shorten post-diagnosis survival. So we saw highest dementia incidence rates in African Americans and lowest dementia incidence rates in Asian Americans. But if this was solely due to earlier diagnosis in African Americans and later diagnosis in Asian Americans, then we would also expect longer survival after dementia diagnosis in African Americans and shorter survival after dementia diagnosis in Asian Americans. So here are our estimates of survival after dementia diagnosis by race ethnicity. And so we see here that dementia incidence rates were actually shortest in non-Latino whites with a median survival time of about 3 years, and longest in Asian Americans with a median survival time of almost 4.5 years. So these results are not in line with the conceptual diagram where we would have expected shorter survival after dementia diagnosis in Asian Americans if they were just being diagnosed later in the disease process. And also not longer survival times in African Americans if they were just being diagnosed earlier. And here I'm just showing you the median survival times for across just in each racial ethnic group, but I will say that these trends were evident also across age bands and also persisted after adjustment for comorbidities. So what are the most likely explanations for these racial ethnic differences in survival after dementia diagnosis? So we really thought we needed to compare these racial and ethnic mortality patterns among people with dementia to patterns among older adults still in the Kaiser system without dementia diagnosis. And what we found was that the racial ethnic mortality patterns among people with dementia tended to parallel patterns among dementia-free older adults. And so really the implication is that the same factors driving racial and ethnic mortality differences in people with dementia is probably the same as people without dementia. So it was really key, I think, for us to really look at the dementia incidence rate, or sorry, the racial ethnic differences in survival among people without dementia to try to understand the patterns that we observed among people with dementia. And so this finding that we don't seem to see differences in racial ethnic mortality patterns among people with dementia compared to people, the racial ethnic patterns among people without dementia really, I think, provides some evidence that the timing of diagnosis is not a major driver of the estimated racial ethnic inequalities in dementia incidence. So from this work, you saw that on average, most people are living for years after dementia diagnosis. And so this really has inspired some of my more recent work thinking about quality of life among people once they have dementia. I think as an epidemiologist, I originally started only thinking very much about prevention, and I'm still very interested in prevention, but I think that as we work towards understanding determinants of dementia and hope to identify strategies to prevent and delay dementia, I think it's also important for us to think about the millions of people currently living with dementia and the people who care for them, and think about trying to understand how to improve quality of life for people living with dementia. So I'll present some of this work that was led by Dr. Eleanor Pace-Larson, a postdoctoral fellow I work with at UCLA. And so our goal here was to, in terms of just getting started with trying to understand quality of life among persons living with dementia, our aim here was really to determine if there are racial ethnic differences in poor health-related quality of life among people living with and without dementia in a nationally represented cohort. So for this, we used data on about 10,000 community dwelling older adults ages 65 and older from the National Health and Aging Trends Study, or NHATS. And we just conducted age and sex-adjusted generalized estimating equations to estimate prevalence ratios and prevalence differences in health-related quality of life by race ethnicity. And so here are our key findings here. You see that we have each indicator of poor health-related quality of life going across the rows here. And here on the left, we have Black versus white and Latino versus white prevalence ratios. And on the right, we have prevalence differences for these indicators of poor health-related quality of life. And the different blue shades represent people along the cognitive decline continuum. So light blue indicates persons with no dementia. Medium blue represents people with possible dementia based on the NHATS cognitive assessments. And the dark blue represents people with probable dementia based on the NHATS cognitive assessments. And so really you see here that when we, one of the things that really jumps out is that on the, we see larger disparities, racial ethnic disparities in health-related quality of life on the ratio scale than on the difference scale along the cognitive decline continuum. So we see here, for example, we see larger differences in health in fair or poor health among people without dementia than people with dementia on the relative scale here. But we don't see as large of differences in the biodementia status on the prevalence difference scale. And so I think really here this suggests that the absolute amount of unmet needs is really similar along the spectrum of cognitive decline. And so I think that one of the key aspects of thinking about how to understand documenting racial and ethnic inequalities in dementia, I think this is one clear case where we're never just interested, we're never just interested in the people in our study. When we're trying to document racial and ethnic inequalities in health, we're really always trying to extend findings or generalize, we hope to generalize the findings from the people in our study sample to broader populations. And so now I'll talk about some of my work with that in mind. So this work uses data from the Kaiser Healthy Aging and Diverse Life Experiences Study, or KHANDLE study. And this study, our really broad goal is to understand the major life course mechanisms driving racial and ethnic inequalities in dementia research, because although, as I mentioned, there's a need to document racial and ethnic inequalities, there's no point in documenting the racial and ethnic inequalities if our long-term goal isn't to understand the inequalities and promote equity, promote racial ethnic equity in aging. And so for this study, this is a study of about 1,700 long-term Kaiser Permanente Northern California members. And we recruited approximately equal numbers of Asian Americans, Black Americans, Latino Americans, and non-Latino whites who were long-term health plan members who participated in these multiphasic health checkups in Kaiser, this optional clinical study that ranged from the 1960s to the 1990s. And then of those people, we looked at people who were still health plan members in ages 65 and older without prior dementia diagnosis in 2017 when we started our study. So we have life course data ranging back from the 1960s, from the multiphasic health checkups. Then we have the electronic medical records starting in the 1990s. And then for KHANDLE, we started following people in 2017. And I meant to update this to 2025 or 2026 because we just got a renewal. So we're about to start cycle 2 of the KHANDLE study and continue following participants. So this is again the work now that I'll present on extending findings from KHANDLE, again led by Dr. Eleanor Taze-Larsen here. And so we know that KHANDLE is more diverse than many studies, but selection issues still persist. In particular, we always know that we can be worried that people who decide to participate in cohort studies where we're following people repeatedly, we're asking them a lot of questions, we're taking physical measurements, that people who participate in studies might be different than people who don't participate in studies. And also we know that KHANDLE is distinct from the general population in an important way, in that KHANDLE participants are all long-term members of Kaiser. So these are all people who've been long-term California residents and have had long-term access to medical care. And so our goal here is to try to use the KHANDLE data and use transportability methods to extend findings from KHANDLE to the California population. And so our target population here is the California population of older adults, represented by the California BRFIS, or Behavioral Center for Disease Control Behavioral Risk Factor Surveillance System. So we took the BRFIS as our population representative sample. And then our goal was to model the sample selection process into KHANDLE. So think about how KHANDLE participants differ from the BRFIS participants. And you can see over here some of the differences. For example, even though we have representation in KHANDLE across the educational spectrum, we still slightly overrepresent people with higher levels of education and underrepresent people with lower levels of education. And you can also see, for example, we also, KHANDLE participants had slightly better self-reported health than the general population of California, for example. And so our goal is to take our understanding of the differences between KHANDLE and the California population represented by BRFIS to then model the selection process and transport the estimates from KHANDLE back to the target population. So the transportability method that we used here was that we used weighting to account for differences between the KHANDLE and California BRFIS samples. And so this figure here shows the standardized mean differences in different variables between KHANDLE and BRFIS, and the different colored dots represent different racial ethnic groups. And this is before weighting, and this is after applying weights to basically create a pseudo population from KHANDLE to look more like the California Burfus population. And you can see here that even though the standardized mean differences between weighted KHANDLE and Burfus still remain, not all exactly zero, the weighted estimates, the weighted estimates were much closer to zero than the unweighted estimates, suggesting that which demonstrates that the weights did something to make the KHANDLE population look more like the Burfus population, at least on these measured covariates. And so here are the estimates of racial and ethnic inequalities and cognitive impairment prevalence at baseline in KHANDLE, extended to the California population. So as I mentioned, KHANDLE, one of our inclusion criteria was that there was no prior diagnosis of dementia in the medical record. And so most people with cognitive impairment in KHANDLE at baseline had a diagnosis of MCI. There was less than 1% of the KHANDLE sample had met the criteria for dementia based on our study protocols. So most of this cognitive impairment here is MCI. The blue represents the KHANDLE estimates generalized to the California Burfus, and the gray represent the unweighted or the naive KHANDLE estimates. And I have the racial ethnic prevalence ratios in cognitive impairment here on the left, and the prevalence difference estimates here on the right. And so what we see here is that actually the KHANDLE estimates, or the weighted KHANDLE estimates that were generalized to California Burfus, don't look so different than the unweighted or naive KHANDLE estimates, although it differs some by racial ethnic group. For example, we see slightly bigger differences in inequalities for Asian Americans versus whites than the other ethnic groups. And so this is somewhat, I think very cautiously, this is somewhat encouraging that KHANDLE is good for drawing inferences that will generalize to the broader California population. But a caveat with these analyses, as with all studies, is that we're limited to variables that we had measured in common between these two studies, because we could only model the differences in KHANDLE and Burfus if we had measures of based on variables we had in common between the two studies. And so I think a really high priority for future work in terms of understanding drivers of participation into studies is to really make sure that we try to measure these factors that we think drive research participation, and ensure these variables are measured in both the specialized dementia research data sets that we have, as well as population representative samples like the California Burfus or American Community Survey, for example. So a data source that we feel is as population representative as we can get. So we can really work to compare our dementia research studies with these population representative samples and attempt to transport estimates back to these broader populations that we care about. Some of my new work is focused on drilling down into sample selection processes, not just into cohort studies of dementia, but really into Alzheimer's disease biomarker samples. We know that people in these Alzheimer's disease biomarker clinic-based studies with these fancy biomarkers really underrepresent minoritized populations, which I think is really a threat to social justice. We want to make sure that our understanding of Alzheimer's disease is not just limited to a smaller subset of population who make it into see specialized memory clinics and agree to participate in biomarker studies. So this includes participating in Alzheimer's disease research study samples or the ADNI cohort, for example. And I have this diagram here to show how this selection process could be problematic. So I have up here, let's say we have our target population, and the red stars represent people with Alzheimer's pathology. And this lighter blue represents people with lower levels of education, and the darker blue represents people with higher levels of education. So let's say this represents the target population. But then let's say that both Alzheimer's pathology may be due to subjective cognitive concerns or family history of dementia, and educational attainment both influence selection into a study sample. So the grayed out people here represent people who don't agree to participate in the study. So only the people in color here are the people who we actually are able to study. And as a result of this selection process, we see overrepresented people with Alzheimer's pathology and high educational attainment. And in particular, what's problematic is that we see an enrichment of Alzheimer's pathology among the low education people who participate in the study. So this sample up here, and which would therefore represent overestimation of educational inequalities in Alzheimer's pathology relative to the target population. So this is just one example of how the selection process could really distort our understanding of Alzheimer's pathology. And so in my new work, our goal is to use methods similar to the methods that Eleanor used in KHANDLE to try to understand how Alzheimer's disease clinic-based samples differ from the target population, and to use transportability methods, so including weighting as Eleanor used in KHANDLE, as well as outcome modeling and doubly robust methods to extend estimates from highly selected biomarker samples back to the populations we care about. And I think then another goal of this is then to really make sure, assuming we can get the methods to work well, to then really package the tools to make them accessible to applied researchers working with these biomarker samples, because we know so much work and so much money has gone into creating clinical cohort studies. And so it's really important we think about how can we make the best use of this available data, as well as trying to make progress in enhancing the diversity of people who participate in these studies. And so now I just want to briefly talk a little bit about some of what I'm interested in terms of moving from documenting disparities in dementia and health-related quality of life among people living with dementia, to really thinking about trying to drill down to understand life course determinants of dementia, which is really relevant for thinking about life course determinants of inequalities in dementia. And so one example from my recent work on this is some work that I've recently did to understand the extent to which work-family profiles between early and midlife influence memory trajectories in later life in women in the United States. So for this, we used a sample of a little over 6,000 women who were born between the 1930s and 50s who participated in the health and retirement study. And each of these women in this sample reported their, for each age between ages of 16 and 50 years, whether or not they were working for pay, whether or not they had a child under age 18 at home, and their marital status. And from this information, we had a picture. We're able to paint a picture of each woman's work-family profile between early and midlife. And so here are work-family trajectories for two hypothetical women. This woman here on the left, we see that she entered the workforce maybe in her late teens, early 20s, and spent her 20s, 30s, and 40s participating in the paid labor force with no children. And this woman over here on her right entered the paid labor force also in her late teens, early 20s, and was working without children, and then spent most of her 20s, 30s, and 40s working and raising children with a partner. So these are just two example work-family trajectories. But of course, there's a lot of work-family combinations possible. And so here is an index plot showing all work-family combinations in the sample. And I'll say here that this work that I am doing built on work by my colleague Erica Sabbath at Boston College, who was one who created all of these sequences. And so we see that there's quite a bit of variability in the work-family trajectories. But from this, we see that we can't analyze each individual unique trajectory. And so from this Dr. Sabbath led a sequence analysis to cluster similar work-family combinations, which resulted in a distinct number, a smaller number of sequences that we could analyze and examine memory trajectories in later life. So here are our main results. We have here, we can see these are the 5 prototypical work family patterns, ranging from women who were participating in the paid labor force. So that's these dark lines here, or solid lines here. And these dashed lines indicate women who spent most of their time not employed in the paid labor force. And you can see we also distinguish between mothers and non-mothers, and among mothers, those who were married and those who were single mothers. And so we see here that at age 60, we really didn't see major differences in memory scores across the different work-family patterns. But as we look at trajectories of change in memory, what really stands out in terms of when we looked at working for pay, marital status, and having children, what really stood out was participation in the paid labor force. So we really see this divergence in cognitive trajectories in the solid versus dashed lines, which represents women who were spent time, a substantial amount of time employed in the paid labor force, versus those who did not, the solid versus dashed lines. So again, at age 60, we really didn't see big differences in memory scores. But then if we look here at the decline between ages 60 and 70, for example, we see, if we look at the memory scores for working non-mothers, the gold line here, at age 70, the non-working groups had already declined to this level by age 65. So really suggests I think fairly substantial differences in memory decline among working versus non-working women. And I'll note that the largest group out of all of these is the working married mothers. And within this group, there was a lot of heterogeneity in terms of some of these women took short amounts of time out of the paid labor force to raise children, and some took longer periods out of the workforce. And we really didn't see substantial differences in memory decline among the married working mothers who continued to work versus took years out of the paid labor force. And so that's why they're all grouped together here. But I think this adds additional evidence that there seems to be a signal that working, even if you don't spend your entire adult life working, seems to confer some benefit for memory decline. So to just wrap up in terms of some of the challenges and opportunities I'm excited about in dementia research. The first is thinking about selection bias. So how can we quantify the potential magnitude of bias and use the optimal tools for mediating bias? So this is really relevant to the work that I'm doing right now in terms of thinking about selection into study samples and tools for extending evidence from our selected samples to the populations we care about. And I think that trying to understand life course determinants of dementia, really thinking about new tools for characterizing life course exposures. For example, that using sequence analysis, which accounts for the order, timing, and duration of exposure. So that's how we estimated these life course trajectories and work family profiles. I think is an underutilized tool in epidemiology that has the potential to help us understand life course or characterize life course exposures, and as well as kind of making life course data sets by linking interview data with rich information on cognitive assessments and dementia assessments and markers of health and old age with administrative records. So for example, linking the multiphasic health clinic data I mentioned from Kaiser from the 1960s with the KHANDLE study that's taking place right now. And again, and then the last thing I want to touch on is also thinking about, in addition to looking at novel risk factors, I think there's also something to be gained from evaluating putative risk factors in diverse populations with differing confounding structures. So I really think that in terms of, I think the reasons that it's important for us to do research in diverse populations is not only to understand dementia, determinants of dementia across the population, but I think that also we can expect that confounding structures might differ across different subsets of the population. And I think there's really something to be gained from evaluating putative risk factors in populations with different confounding structures, which could lead to a better understanding of determinants of dementia more broadly for all people. I'd like to acknowledge my research team and funders, and I'd like to thank your center for inviting me to talk to you today. So thank you.
Great. Loretta said she had to step away for class, so I just wanted to thank you on behalf of the Institute. What a great presentation, and what a perfect presentation to kick off the seminar series. So I'm wondering if there are any questions that we can entertain from the audience. I might kick off with a question then and kind of start it off. So it's pretty fascinating that just work status had such a big influence on cognitive decline in older age. I'm wondering if there was any factoring for socioeconomic status within those working and non-working groups, and perhaps if type of work makes a difference. Like I know there's some research showing that higher cognitively tasking work creates a higher cognitive reserve, which may be somewhat protective. Can you speak to any of those as possibilities?
Yeah, I'm glad you asked, because I think this is something that I've really struggled with in terms of thinking about these results. And I think it's also a challenge with sequence analysis or any life course, trying to evaluate a life course exposure, because we controlled for education, educational attainment, but we were trying not to control for too many factors that were taking place during our exposure period, because we're really concerned about confounder mediators. And so it seems, I'm glad you brought this up, because I think that it seems likely that there could be some confounding by other social factors that are occurring throughout the life course. Although I will mention that for example, the working single mothers, I think were one of the based on the early life course social factors, one of the more disadvantaged groups, and they had similar cognitive trajectories to the more advantaged working non-mothers and working married mothers. So I think one of the things that made me feel a little bit more confident in the results is seeing that the patterning in cognitive trajectories isn't completely consistent with the early life socioeconomic factors. I think also your question about like, what is it about work, I think is something that's really important and fascinating. We didn't get into types of work, but I think understanding what aspects of work might be beneficial seems really important. I think one of the challenges is, you mentioned that whether cognitively engaging work is really relevant for cognitive health. I think one of the challenges is I think that so many different facets of work are also highly correlated. So cognitively demanding work is also probably higher status work that confers more autonomy, safety from chemicals, and higher wages. So I think it's so hard to disentangle, but I think it is really relevant to understand. When we were trying to think about potential mechanisms, like we were sort of surprised we saw such big differences even without accounting for type of work. I think in addition to thinking about possible cognitive stimulation from work being relevant, we could also think that maybe for this generation of women raised in the 1930s through 50s, we could also think that maybe having the independence of being in the paid labor force might also confer like additional social networks, and maybe also I think having some financial independence. So in addition to just thinking about the work itself, there might be other aspects of participating in the paid labor force that could potentially be beneficial. But this is kind of speculation based on other literature because we weren't able to drill down into it. But, yeah.
Great, thank you. That's really interesting.
For my master's, my track is epidemiology. I'm really interested in either pursuing on dementia or Alzheimer's. Since you mentioned that there are selection biases and there are diagnostic concerns that we need to be very particular about, do you think it's a good track to pursue for my practicum or for thesis, considering that it's going to be the start of career? If yes, what trajectory should I be focusing on to, like, as a baby step for this? I would like to hear your thoughts about this. Thank you.
Yeah, well, I have to say I'm probably biased in the forms of bias that I think are the most important. But I think it's, I guess I guess I in particular have chosen to focus on selection bias, and then I'm also concerned about measurement issues. But I guess in terms of advice for people who are just starting out and choosing their trajectory, I think that what's really relevant is thinking carefully about the methods for I guess mental health research or dementia epidemiology more broadly. And then with that, I think it's really relevant to think about what are the methodological challenges that you see as relevant that you're most passionate about. Like which methodological issues just are really going to bug you and that you can spend years trying to disentangle, because we really need. I think our field would become really lopsided if we only had researchers who are focused on one source of bias. And so I think that it's really important that we have researchers with different perspectives who are fixated on fixing different problems, is really crucial for strengthening our field. I hope that's helpful.
Great, thank you so much.
Hi, I have a question. So I know in your presentation, you had something about diagnosing later and earlier. And I know sometimes, and there's a difference between racial groups, and I know sometimes that's related to their values and beliefs. Have you found any other psychosocial variables that were of interest to your research?
Yeah, I think that's really relevant. I mean, I think that the work that I presented, we were trying to understand potential differences in diagnosis by race, ethnicity. There, we were just using electronic medical record where we had very little information on people. But I think that leveraging data from the KHANDLE study, so these long-term Kaiser members, where we have regular dementia assessments, and we also have important social exposures and psychosocial measures, and can link that with EHR-based diagnosis information, I think can really help us try to understand, get a richer understanding of diagnosis patterns, not just thinking about race, ethnicity, but as you mentioned, when we think about race, ethnicity, we're really thinking about a lot of different factors. And so one of the things I'm excited about with the KHANDLE study being nested within the Kaiser system is we can really look at the richer information that we have on participants who are participating in KHANDLE and link it with the EHR data. And we'll then also not just try to infer delays in diagnosis based on survival time after dementia diagnosis, but if we have, since we have cognitive assessments and dementia assessments, we can also try to understand the difference in timing between when somebody receives a dementia diagnosis in KHANDLE versus when we see it showing up in the EHR. But I think you make a good point that I think it's probably quite relevant to think about psychosocial factors in terms of potentially influencing timing of diagnosis.
I think I might throw out another question here. Recognizing my bias as a physical therapist, I saw on one of your charts that you had gait speed and mobility. How do you think overall activity and mobility factors in?
Yeah, I mean, I think one of the factors that I guess one of the things I struggle with a little bit in terms of thinking about physical function measured in old age and other health outcomes, and sometimes it's hard to know to what extent like disentangle the process. Are people's cognitive health, is it better because they're physically strong and physically active, or is it the same? Is it representing the same process that we might see a decline in physical performance and a decline in cognitive performance? But I think that it certainly, I'm interested in thinking about ways to try to disentangle and understand whether interventions to promote physical function and physical activity in late life could also extend cognitive health as well. I don't know, what are your thoughts?
Yeah, I think you're spot on. They're so entangled, and even some of the physiological data that we're getting shows that muscle contraction and brain health are so tied. And so how do you disentangle that? And is there a way to really create the right intervention for each population and what that looks like? So yeah, I think you're exactly right. There's like decades of research to do there. So. Nan, thank you again so much for kicking off this seminar series. And everyone in the audience, please check out our website for the GW Institute for Brain Health and Dementia. We also have an active Twitter profile that Victoria is managing, so thank you very much for that. And one last round of applause for Dr. Mayeda, and thank you again. Thank you very much.
Great. Thank you so much for having me. Okay, take care. Bye.
You too.